And this time we're going to get Dr. Kastritis and Dr. Tedeschi to come up and lead the next session, which is entitled Associated and Secondary Malignancy Risks in Waldenstrom's Patients. This, I have to say, was one of the most exciting topics brought up at this year's workshop. And we have really a lot of important presentations that were made from which I think we have the opportunity to learn from. And both Dr. Kastritis and Dr. Tedeschi have a particular interest in this area. So we're very lucky to have their expertise here today. So I'm going to turn it over to Alessandra and Stathis at this point. Please welcome them.
Thanks. Thanks, Steve, for involving me. I am very happy to be with you. It's my first experience with patients in the United States. So I will start, if I will be able to start. Okay, so as I said, it's not the most pleasant presentation, but is a topic of interest. And if you have seen this from the New York Times, it was an article that appeared in the December of 2017, just for Christmas, in which they analyzed the problem of the second new cancer. This is important, as I said, because if you take about 7,000 individuals diagnosed with cancer in 5 years, 18% of them have a second new cancer. And so there is a higher risk, a second new cancer prevalence that goes from 4 to 37%. The risk is higher in the elderly population. So if we take together all the list of cancers and we look at the line of lymphoma, Waldenstrom is a lymphoma, we can see that the occurrence of a second cancer in the most young population is about 4.5%, and for the elderly is 18.7%. Of course, there are a lot of mechanisms that may contribute to the development of secondary malignancies. The first thing is genetic predisposition, so mutations genes that may increase susceptibility. There is another important thing in these diseases that is immune dysfunction. All patients with lymphoproliferative disorders have immune dysfunction. Of course, environmental factors. And the other thing we have to pay attention is therapy. Therapy has carcinogenic and immunomodulatory properties, but at the same time, with therapy, we prolong overall survival of our patients. So there is a higher risk, and Waldenstrom is a disease of the elderly, to develop a secondary malignancies. During the workshop, we had a talk from Dr. Castillo about the higher risk of unrelated cancers in Waldenstrom macroglobulinemia. And he showed that the results from the registry, and this is a good news, and the good news is that if we consider 2 decades of observation, that is 91, 2000, and 2001 and 2010, you can see how there is an improvement in overall survival in Waldenstrom patients in the last decade, and this applies to all category of patients, younger and elderly. And the other important thing that he showed, looking at the data of the registry, is that the majority of patients do not die from Waldenstrom. You can see in the left part that this is the Waldenstrom-related deaths, while the majority of patients die for causes that are not related to Waldenstrom. And this is most true for the elderly patients. Now, if you look at the cumulative incidence to develop a second cancer, this is a different graph for hematological malignancies and solid tumors. You can see that the cumulative incidence to develop a solid tumor is about 7% at 5 years, and then 12 at 10 years and 15 at 15 years. While the hematological malignancies, the cumulative incidence of at 5 years is 2.3%, and at 10 years is about 4%. Now, if we look at the population of the registry, we can see that patients that are higher risk of developing a secondary malignancies are the younger patients, that is less than 65 years. And the development of cancer is more often observed after the 5th years from Waldenstrom diagnosis. There are some cancers that are mostly observed in patients with Waldenstrom and are more often observed rather in the normal population. That is thyroid cancer, melanoma, lung cancer, and urinary tract cancers. My topic was to address how treatment is important in the development of secondary malignancies in this disease. We certainly know, because we have learned this also from other hematological malignancies, that are treatments that may have a role in the development of malignancies. And from chemotherapy, we have to underline the role of chloramucil, cyclophosphamide, anthracyclines, and other drugs that are not commonly used in Waldenstrom. Radiation therapy is not used in Waldenstrom, but is used in solid tumors, for example, and has a role in the development of secondary malignancies. The role of nucleoside analogs is known from 2009 when Lelay published this paper. This was a paper in which he analyzed 439 patients treated with purine analogs, or patients not treated or treated with other compounds. And as you can see, he observed a higher transformation risk in patients treated with purine analogs when compared to the other two population. So at the conclusion of the paper was said that for sure nucleoside analogs have a role in development of secondary malignancies, and mostly hematological malignancies. On the other hand, some controversial and different results were drawn from this study, which is a randomized study, fludarabine chloramucil. And in this case, fludarabine was not an issue for transformation in large cell lymphoma, while it was in the previous study, while alkylating agents were responsible of a higher risk of secondary malignancies development. So what is the real role of treatment is difficult to determine. And for this workshop, I looked at the literature of the last 20 years to understand if there was a compound that was more responsible than the other in the development of malignancies. And you can see that from all the studies, we put together all patients in all the trials appeared in PubMed in the last 20 years. And as you can see that from here, that fludarabine and chloramucil are considered the most important agents that are responsible for secondary malignancies development. But to understand if a treatment has a real role in indolent disorders is very difficult. While with aggressive disease is more simple, you have an aggressive disease, you give a limited number of treatment, and then patient goes in complete remission and stays in complete remission, and after that he may develop secondary malignancies, and you can think that the secondary malignancies is related to the treatment he received before. Different is for indolent lymphomas, because during their lifetime, patients are exposed to different lines of treatments and different agents, so it's difficult to understand which agent is responsible for the secondary malignancies. So there is a Latin proverb that says post hoc ergo propter hoc, which means after this, therefore because of this. Is treatment responsible of everything? We don't have to incur in false cause fallacy. Now, when I went to my statisticians, I don't know if there is a statistician here, but statisticians are a bit a strange category in my hospital. And I said, I want to see if secondary malignancies in my patients are related to a certain treatment. He said, impossible. You can't do this work. And I said, why? And he said, because you can incur in false cause fallacy. And he showed me these graphs. So the divorce rate in Maine is proportional to the consumption of margarine. And this is a false cause fallacy. People buy less margarine and divorce. And the other thing that goes together is stop global warming, because there is a relationship between the global warming and to become the number of parrots we have in the world. Okay. So he said, are you sure that this treatment is responsible for your secondary malignancies? And I said, no. So he said, it's impossible to do this work. So to be sure that the treatment is responsible for the development of something, you have to have a lot of studies on this matter. And it's like this relation, which is not a false cause fallacy. We know that lung cancer is proportional to smoking. But we know that smoke develops lung cancer. So what we did is that we saw at our patients, 333, and we found that 27% of them had another malignancies. In 9.6% of patients, the malignancies was diagnosed before Waldenstrom, so Waldenstrom was the secondary malignancy in this case, while in 17.4%, secondary malignancies was diagnosed after Waldenstrom diagnosis. So we took only our treated patients, that is 209. Again, we had 61 patients with malignancies, 16 before diagnosis and 45 after Waldenstrom diagnosis, and the majority of them, that is 43, had developed cancer, a second cancer, after treatment. Then we compared our treated population versus the untreated population. As you can see, taking together all cancers, there was not a significant difference between the two groups, while the significant difference was when we compared patients developing secondary malignancies after treatment versus the other population. And there was a significance P with 0.035 with an odds ratio, which is a sort of risk of 2.04. Then we compared which kind of malignancies our patients developed. And you can see that while there were a similar number of solid tumors between the two groups, what was statistically significant was the development of hematological malignancies. So we had a higher incidence of hematological malignancies secondary to treatment in treated Waldenstrom patients rather in the untreated patients. So if we take together the 209 patients, we had 11% of patients developing solid tumors after treatment, while the other 9% of patients had secondary hematological malignancies, that is 9 histologic transformations and 10 myelodysplastic syndrome or acute myeloid leukemia. We found that the median age at the second malignancy was similar when dividing patients according to the 3 groups, so solid, histologic transformation, and acute myeloid leukemia, and was very similar also the median time from treatment to the development of secondary malignancies. That is about 5 years. If we look at the characteristic of secondary malignancies, we had histologic transformation characterized all by high-grade lymphoma. We had 1 direct acute myeloid leukemia and 9 cases of myelodysplastic syndrome that then developed acute myeloid leukemia. And when we look at the solid tumor, we had an excess in respect of the normal population of urinary tract tumors, gastrointestinal, and breast. If we look at the cumulative incidence of secondary malignancies development, we can see that the majority of patients, that is 54% of patients, developed a secondary malignancies in the first 5 years. And then we looked at the risk factors. And none of the clinical and disease characteristics had an impact on the development of secondary malignancy. We then looked at the treatment, if treatment had an impact on the development of these malignancies. And if we look together at all the 43 patients, none of these treatment, so alkylating agent, purine analogs, or rituximab, were predictive for development of secondary malignancy. But when taking only acute myeloid leukemias or myelodysplastic syndrome, we saw that patients exposed to both fludarabine and alkylating agents had a higher risk of development. And this is in line with what normally the literature says. It's not enough fludarabine alone, but if you have been exposed for a long time to alkylating agents and fludarabine, you have a higher risk of acute myeloid leukemia or myelodysplastic syndrome development. After my presentation, Roger Owen from Leeds showed the results of the UK trial, which is a randomized trial, and this is the design of the study, in which they compared the so-called FCR treatment, which is fludarabine, cyclophosphamide, and rituximab, with bortezomib, cyclophosphamide, and rituximab. We really don't use anymore purine analogs in first-line treatment, but in England still FCR is considered the standard of care in first-line treatment. Just to let you know what is myelodysplasia. Myelodysplasia is a hematological disease, of course, mainly of the elderly, in which there is a block in maturation of the normal cells in the marrow. So the marrow is packet of immature blood cells, and in the peripheral blood we have cytopenia. This because this normal cell do not arrive to the normal maturation. And he observed in patients treated with FCR, 3 patients, that is 17% of patients. It's true that the number of patients enrolled in this trial was small, so 70% may seem very high, but the number of patients enrolled in the FCR arm was only 17, developed MDS. So you could say, okay, you told us that fludarabine may have a role in myelodysplastic syndrome development. What's new in this? The new thing is that they observed at the peripheral blood of patients before FCR treatment, so the basal peripheral blood, and they found in 17 of the 56 patients enrolled in the trial some mutations. And those mutations are typical of myelodysplastic syndrome development. So there is another concept I am trying to explain, which is a very new concept in hematology, and everybody is looking at this thing now when we speak about myelodysplastic syndrome and acute myeloid leukemias, that is clonal hematopoiesis. Clonal hematopoiesis is a sort of pre-disorder. It's like IgM, MGAS, and Waldenstrom. And we have clonal hematopoiesis and myelodysplastic syndrome. We don't know that we have clonal hematopoiesis because we have normal blood cell counts, but we can have in the blood some mutations that may predispose us to the development of a myelodysplastic syndrome. This is an aging-related phenomenon. We can find clonal hematopoiesis is less than 1% of patients, of normal patients. They are not patients in normal population, aged less than 40 years, but is present in 10–20% of the population aged over 70 years, which is the population which is affected of Waldenstrom. So what happens in this case? Treatment may have a pressure on the development of an expansion of these cells that are mutated and determine acute myeloid leukemia and myelodysplastic syndrome. But potentially this patient may have myelodysplastic syndrome and acute myeloid leukemia in the same manner years later, even if they are not exposed to treatment. So I have finished my part, and now Stathis will tell you everything about screening.
Thank you very much, Alessandra. So, as Alessandra showed, there is an increased and real risk of second malignancies, of second cancers in patients with Waldenstrom's. Can we do something for that? Probably it is very difficult to do something to prevent, but maybe we can do something to detect early these second malignancies, so to treat them effectively. So going back to the basic questions, what is the risk of a second primary malignancy? Alessandra showed that. I will just briefly show you a couple of slides just to put everything in perspective. Second, which are the most common second malignancies? This is very important because we do not have tools to screen for every cancer. At least at this time point, we have to focus only on the cancers that we can prevent, on the cancers that we have effective treatments, and the cancers that really is important to detect early. Because for some cancers, it doesn't make any difference, because even if we detect early, we can do only a few things. So this goes to the third question, is for which of the cancers that there is an increased risk, we do really have reliable screening tools. And of course, a question for every screening procedure is, what are the potential benefits and harms? Because, of course, screening may be easy if it's a non-invasive procedure, but there are procedures that may be invasive, and we all have to be ready to do something with the results that we get from screening. Because if the results indicate that there may be something there, so we have to do this type of biopsy, or we have to do this type of procedure, then the risks are not zero. There may be a real risk with all these interventions. So we have to be ready at least mentally, to have something to do with the results of the screening. Now, the risk of a second cancer among patients with lymphoma is about 2 to 3 times higher than in patients with other solid tumors. So compared to patients that had breast cancer or prostate cancer, patients with lymphoma do have a higher risk of second cancer. And as Alessandra showed, there are many factors that are implicated for this in this increased risk. For example, immunosuppression is a very critical point that increases the risk. Second, the risk of cancer increases with age, and this is something that we all have to live with. If we all live long enough, all of us will get some cancer. This is evolution, and this is something that we have to understand. As you saw, clonal hematopoiesis starts very early, and if everyone lives enough, probably will get MDS, or prostate cancer, or even breast cancer, or some other type of cancer. So we have to understand that this is a real risk, and we have to be aware that as the time passes, the risk increases. Now, which are the most common second malignancies? These are data from patients with various cancers. I'm focused here on patients with non-Hodgkin's lymphoma, and the next slide will focus on Waldenstrom's patients. And as you can see, 51% of second cancers are lung, prostate, breast, and colorectal, which is actually the cancers that we expect in patients without lymphomas and without Waldenstrom. So the same cancers also apply in patients with Waldenstrom's. And the good thing is that for these cancers, we have things that we can do. Now, specifically for patients with Waldenstrom's, as you can see, there are some of the cancers that in which the risk compared to other patients with other cancers is really increased, like thyroid cancer, where there is an increase in the risk of 2.67. However, this is a rare cancer. As you can see, this is 10 cases. So there is an increased risk of a rare cancer, most of the thyroid cancers are treatable. What I want to point mostly here is that lung cancer is the major killer in this series. About 20% of the second cancers are lung cancers. So, of course, the risk is 48% above the average, but still, the major issue is that this is the majority of second cancers. As you can see, breast cancer, for example, the risk is not significant increase, it's more or less the same, just like prostate cancer with the, as for the other patients. Now, we do have reliable screening tools for breast cancer, for colon cancer, for prostate cancer, for cervical cancer, for lung cancer. For other cancers, for pancreatic cancer, for example, or for ovarian cancer, we do not have very reliable screening tools. And in most cases, we either miss the cancer or we detect false positive results. And this goes to an endless story of tests and additional tests and additional tests. But what happens in patients with Waldenstrom's that are unlucky enough to get a second cancer, and this is a breast cancer? These patients, at least in this data series, which is a very large series, more or less have the same outcomes as patients without Waldenstrom's who had breast cancer, and this is okay. It's okay. We would like that this line was flat, but still there is it means that we can manage this cancer very effectively even in patients with Waldenstrom's. The most important thing is to prevent because and detect early, because we can detect early breast cancer, and this is what has reduced the mortality from breast cancer. So I think it is very important for patients with Waldenstrom's to follow exactly the guidelines for screening for breast cancer, which are based on risk factors that are associated with age, with menopausal status, with family history, and not with the pre-existing history of Waldenstrom's disease. Now, what happens with colorectal cancer? Colorectal cancer is another cancer which is, if detected early, is curable in the maybe 90-95% of the cases. For colorectal cancer, early detection is the key for the cure. Now, as you can see in this slide, the dotted line indicates the outcome of patients who do not have Waldenström. So as you can see, at 5 years, the survival is about 56%, 55%. But for Waldenström patients, it's 31%. So this means that there is a high probability that this cancer is detected late in the course of disease in patients with Waldenström's. Why? I think this means that we have to be careful. One of the earliest signs of colorectal cancer is anemia. So it is very probable, I'm not saying that this is the only reason, but we have to be very careful with that, that in many patients with Waldenström's, we see a decline in the hematocrit and we say, okay, it's a disease, let's start chemotherapy. But maybe this is a anemia associated with colorectal cancer. So I think it is very important always to remember that in a patient with Waldenström's, the reason for anemia may be different than Waldenström's, and one has to be very careful and discuss all this with his or her physician. And this is very important, and it is very important to remember that for all adults above the age of 50 at average risk, which is mostly maybe 90% of the population, the need for colonoscopy. For those that are at high risk for other reasons, family history or history of multiple polyps, etc., or Lynch syndrome, there is another set of guidelines. What about prostate cancer? Now, prostate cancer is a very difficult cancer in terms of screening research. You may have read a lot of papers or articles showing that in Europe, for example, the studies that tested screening for prostate cancer did not show a significant improvement in overall survival. In the United States, the other studies showed improvement in overall survival. And there is a mixture of opinions. There are 7 different guidelines from different entities on whether prostate cancer screening should be offered in all males above the age of 50. I will not get into this discussion right now. More or less, patients with Waldenström's who develop prostate cancer as a second cancer have quite similar outcome with the other patients that develop prostate cancer. These are the screening guidelines from the US Preventive Services Task Force, which is a little bit against screening. Personally, I'm for screening for prostate cancer, but I'm not the most specialist in this case, and I think that the NCCN guidelines are probably better to follow in this case and offer prostate cancer screening after, of course, discussing with the patients the pro and cons of screening at an age that really makes a significant difference. Now, I think for lung cancer, we have to check on the curves and see that indeed patients with Waldenström's and patients without Waldenström's have very similar outcomes with lung cancer. The problem is this is because both have very poor outcome. And this is very important to remember that lung cancer is a disease that still we can only cure in very few patients. And it is very important to address the issue of prevention. And prevention for lung cancer means stop smoking. So the major risk factor for lung cancer is smoking. increases the risk by 20 to 40 times, while having Waldenstrom's increases the risk of lung cancer, according to the studies that I show you, by 48. It's less than twice. So it doesn't make any major difference whether one has Waldenstrom's or not. There are the other factors that affect the risk for lung cancer. Now, should we screen for lung cancer? This is a very complicated issue. There are online tools in which you can use your physician to define whether the risk of lung cancer is high enough to start screening for lung cancer, because screening for lung cancer is not something easy. It means yearly computed tomography, low dose of course, but still it's a CT that you have to do every year, which is some radiation also, and the risk of false positive and false negative results. So one has to be very careful in saying, okay, let's start screening for lung cancer everyone. There are specific guidelines for that. There is a marginal, in my opinion, a marginal benefit from screening for lung cancer. And there is always the risk that one may think that since I screened myself for lung cancer, I don't have lung cancer, I can continue smoking for another year. There is always this risk with screening. Now, melanoma is a malignancy that is associated with poor outcome, especially in patients with lymphomas. And as you can see here, patients with Waldenstrom's who get melanoma really have a very poor outcome compared to the other patients. Why is this happening? The issue of immune suppression because of Waldenstrom's or because of therapy is very critical. And as you know, or have you read, treatment of melanoma today is based on immunotherapy. So if you do not have a very fit immune system, then it is difficult also to fight melanoma, but also there is a risk to develop melanoma. So I would suggest to follow the guidelines for the early detection of melanoma and follow the guidelines of your dermatologist, and also inspect the skin and avoid excessive exposure to sunlight or other means to get a nice tan. So, okay, Waldenström survivals are at increased risk for second cancers. Not all Waldenström's patients are at high risk for a second cancer. But everything has to be thoroughly evaluated, and I think the best strategy is to adhere to the guidelines that exist and the recommendations for screening for cancer according to the age of each one of our patients and all of us, actually. And until we have some more data on how to prevent cancer, this is the safest way. Thank you very much. Should Alessandra come on stage to
Yes, please.
start the discussion?
I had a question for both of you, and maybe even Jorge Castillo. But I was always very impressed in clinic, sometimes when I saw people after drugs like fludarabine and how they started having skin cancers. You would see both melanoma, non-melanoma cancers, and that kind of association of time when they got fludarabine therapy seemed to correlate. And I'm wondering, when you look at this kind of data, which is a little bit dated because it goes back many years when we were still using nucleoside analogs, whether or not the incidence today might be lower, potentially because we've moved away from those drugs. I wonder what your thoughts are, because you've given this a lot of thought in your analyses, and wonder what that impact might be.
I don't really know if the incidence of melanoma is lower. I think that there is also an issue with ibrutinib and skin cancers. not melanoma maybe, but basalioma and spinocellular. But immunodepression has a really important role. And I don't know if it's only a problem of fludarabine, but it's a problem of 3 or 4 lines of treatment at the end of the story.
Now, in our database, we haven't seen any major change in the risk of melanoma or other solid tumors, but specifically for melanoma in the era before or after rituximab. So, because before 2000, we were also using some fludarabine. After 2000, we don't use so much fludarabine, but we haven't seen any major difference. Of course, the numbers are small, and the confidence interval is quite wide. But I think that from a drug that causes severe immune suppression, we know that fludarabine is very immunosuppressive, we would expect to let a tumor that is controlled by the immune system to get away.
And I think an important question for the audience is, at the end of the day, what kind of screening would you recommend? Would there be any additional screening that you would recommend for patients with Waldenstrom?
I think that every 6 months skin inspection is probably the safest. Patient education is very important, but the specialist is always more experienced to detect if something is wrong. The skin color is very, very important. We have seen that. I'm coming from a place where the sun is 320 days a year, so skin cancer is an issue. So the skin color is very important, and especially for those who are fair-skinned, I think this is probably the best way to also consult a specialist.
Yeah. No, I think that's actually a very important point, because both in CLL as well as Waldenstrom, we do see this increased risk of skin cancer. And some of the studies in Australia, where you see people, in very, sun-prone areas, we have seen that, higher risk of skin cancer, but also when they do get skin cancer, they tend to be more aggressive. Yes. And so that's really why I think I agree with you that, being able to have people get regular skin examinations is very important, particularly if they're on therapy. But even without therapy, it's probably a good idea.
Yes, because we don't know when the immune system is ready to control any cancer cells, yes.
Just 2 questions, I guess. The first one was, my oncologist has always told me to get checkups with my skin doctor every 6 months, which is great. But he also says that I should be wearing, particularly during the spring and the summer, some suntan lotion every day. And that you shouldn't go out without having some sunscreen on. And so I don't know, it sounded like that's sort of what you might recommend as a standard approach for those of us with the higher exposure.
Absolutely. There is a hole in the ozone, in the ozone layer, and we are lowering risk for skin cancer. I mean, having preventive examination doesn't mean that you shouldn't use a sunscreen or a hat.
But this is said normally also to the normal population,
Everyone.
Not only to patients with indolent lymphoproliferative disorders. Right. Every dermatologist will say, don't go to the sea, put something on, don't go under the sun.
I think this is a nice question, showing one of the risks of talking about screening.
Yes.
So that having screening tests and screening tests being negative for a cancer, one may feel safe. Mm-hmm. And this is one of the risks of, suggesting screening to everyone for everything. Every screening test has a limit of detection and a false negative rate, meaning that there is something there, but it's not found by the screening test. So you should follow your dermatologist or your oncologist advice, and also use sunscreen. You should screen for lung cancer if there is an indication, but also quit smoking.
This is called prevention, not
I
screening.
mean, no, because one
It's
may
called
think, okay,
prevention,
I'm
yes.
screening, okay, my lung is clear this year, okay, another year, one more year of smoking.
So the second question I had is, after I was about a year after I was diagnosed with WM, and I wasn't on any chemotherapy, I was on watch and wait at the time, my oncologist told me that I should get a prostate biopsy. And my urologist was kind of surprised by that because my PSA hadn't been going up dramatically. There wasn't anything to show, but he went ahead and did it, and my prostate was riddled with cancer, and I had it removed and so on. It seemed to me to be kind of extreme that everybody, just because you had WM, you should have a biopsy of the prostate. On the other hand, he did find a pretty serious cancer that I've been able to take care of. I'm just curious about, because you showed the incidence of prostate as being one of those for men. Are there any special things men should be doing before?
Well, prostate cancer is very, very common cancer.
Right.
And after starting screening with PSA, we have seen a shift in the prostate cancers that we detect. Most of the cancers that are detected today are very early, low grade, and probably in situ cancers that will never cause a major problem. That is why we have so many discussions about whether really we should offer to everyone screening for prostate cancer. And biopsy without a specific cause, I don't think is a recommendation by any authority.
Right. Thank you.
Yeah, I'll just share my personal experience with melanoma. It seems like I have this weird relationship with Waldenstrom's and melanoma, and it probably goes way back to when I had MGUS decades earlier, before the Waldenstrom's. And I've had multiple melanomas, and they're actually, I'm probably up to about 5 right now, but they're all non-invasive. 4 of them have been in situ, and I don't think they're treatment related, maybe, but I only had one hardcore chemo, and that was back in 2002, 2-CDA. But since then I've had targeted therapies, and still seem to be developing these low-grade melanomas, and non-life threatening, so I'm not that concerned about it, but it just seems like there's maybe an immune relationship going on here. I don't know.
Absolutely.
Maybe,
Yeah.
yes.
Absolutely.
Not everything is treatment related.
It's what?
Not everything is treatment related.
Right, right.
Yeah, and a lymphoma affects the ability of the immune system to control infections and cancer cells. So, of course, there is a relationship.
Thank you.
The degree of relationship, of course, is something, as Alessandra showed, it's difficult to assess.
This may be more a question for a gastroenterologist, but if you're becoming anemic, should you ask a gastroenterologist about doing a fecal occult blood test, do you think, since it's so simple to do, or is that?
I think when we have a hematocrit result, we also look at other parameters of the CBC to see whether, we have a low ferritin, to see whether the blood cells, the red blood cells become smaller, which means that there is something wrong there. Maybe there is iron deficiency. And I think that if we see iron deficiency, the first thing that we have to do is consult with a gastroenterologist and do a test for fecal occult blood, as you said.
Okay, thank you.
Along the same line, do you see a role for like Cologuard type of things for people who especially are on medications that you don't want to put on holiday for a colonoscopy, for screening?
For colonoscopy? I'm sorry, I didn't catch that.
Cologuard,
Yeah, you said if there is a?
If instead of colonoscopy, for those patients who are on medications for the WM that would you don't want to put on hold to do a colonoscopy,
I don't think that you have to. And I think Jorge and Dr. Treon talked about holding drugs for a simple procedure.
So the testing that we are referring, the testing that the Cologuard is actually a relatively new test that just we're starting to use in the United States, kind of replacing, trying to replace colonoscopy and other markers as a screening for colon cancer. My sense is there's some data supporting that, so I don't see it should be a problem to actually use it. But I would use it in the right context, and you should discuss that with your primary care physician in terms of the frequency of the screening. It's a kind of a DNA-based test from stool. Yeah, it's a little bit different, but it's up and coming, so that's why they're asking about it.
I don't know if you've ever heard of it. It's called the Levelin stick. It's a gel that they put on your face. My dermatologist wants to do it on me, and it's been Medicare approved, and they're doing it in Florida. Levelan, I believe it's called, and it's a gel they put on your face, and then they put you under a blue light for a half hour, 45 minutes, and after that, it brings out any cancerous cells that are on your skin that they can't see. It'll bring it to the surface so that you don't have to wait until. I won't do it. My dermatologist wants me to do it. I said I have to check with my doctors at Dana-Farber to see if I can even do it. I just wondered, have you heard of it?
No.
I don't know this test. Do you know this test?
Have you heard it? I'll bring you the brochure. I'll send it to you.
That's what you get for living in Florida.
We're all guinea pigs down there. It's God's waiting room, by the way.
Yeah, I have seen a similar test. I think it's one to just look at pre-malignant lesions, so I'm not really sure, and I wouldn't be able to comment much further than that. But it is a way that the dermatologists these days are able to use blue light to be able to visualize any malignant and pre-malignant lesions, and they tend to treat them earlier before they become.
Is it FDA approved?
Right?
That's
Is that
what
what
they're doing.
that
That's
is?
exactly
Yeah.
what they're doing.
Yeah.
You said it is FDA approved, though.
Yeah,
Medicare
Medicare pays
approved.
for it.
I wouldn't put anything in my
Medicare
face for
approved.
45
Yeah.
minutes.
Also, I have had a rise in, I've lived in Florida for over 30 years. I'm a sailor, I was a diver, and I do have a tendency, I've always worn hats, and I've always worn sunblock, but now, since I've been diagnosed with Waldenstrom's, I have had squamous cell. You always had basal cell, which was nothing, but now squamous is right below the melanoma. And I had one on my nose. All I had was a tiny little spot, like a red tiny pinhead thing. And it turned out it was a squamous cell. They have to do the Mohs procedure. And I have another one on the back of my leg now they're going to do. So anyway, I've noticed an increase since I was diagnosed with the Waldenstrom's.
Actually, skin cancers are probably very common, but underreported on all these reports.
Yes.
Not only in Waldenstrom's patients, but also in other lymphoma patients, in myeloma patients. But because most of them are basal cell or squamous cell, are underreported.
We used
You're
to
absolutely
underreport.
right.
I forgot the statistic on the number of treatments and the chance of secondary cancers. Is it
No,
proportional or?
No. There is not a proportion of. In our series there was not a proportion number of lines of treatment and the development of malignancies. It's just to say that it's not immediate which treatment may cause cancer, because during your history of Waldenstrom patient, you can receive a lot of treatments, a lot of line of therapies, a lot of compounds, different compounds. And if you develop cancer one day, which will be the compound responsible for your cancer? it's difficult to determine. It's the problem of cause efficacy.
Steve, you want to do closing remarks?
I just want to extend my sincerest thanks to both Alessandra and Stathis for really putting on this fantastic session. And I think we have now arrived at the moment of truth, ending here the International Patient and Physician Summit. And we're very excited that we were able to pull this off. It took a lot of logistics to be able to run 2 meetings simultaneously. But I think what we benefited from was really having an extraordinary faculty that had the opportunity to present an extraordinary amount of information to us. And we learned a lot. I think, in fact, at both the workshop as well as the summit, the dialogue that we had, we all came away with a lot more, and we were very much enriched by the experience, particularly with patients, being able to talk to patients and understand from them what's really critical. At the end of the day, you want to think about, what am I going home with? And what we're going all home with is lots of excitement. We have, finally broken through. I think, I look at the discovery of the MYD88 mutation as our D-Day. This is when we were able to finally break through. And now it's all about trying to make progress, now that we have this opportunity with all this very important information, to run with it and see how far we can get, so we can cure Waldenstrom's. I don't think at this point any of us have any doubt that Waldenstrom's is curable. Waldenstrom's is curable. All the basic elements, the building blocks to getting us there are here now. We will probably improve on them and refine them as the time goes forward, but the building blocks are here now, and that's what I was convinced with at this workshop. And I think very much at the top of that list, for us now, is how to improve, our diagnostic certainty, because all the trials that we're going to go forward with really, have to become, genomically driven, and really taking advantage of this concept of precision medicine, not looking at every Waldenstrom patient as the same, but really looking at people as individuals who may have their own, set of mutations that modify the disease as well as response to therapy. That's why when I say, Waldenstrom's came from being an orphan, where we were just handed down things, now really has the opportunity to become the disease that's going to teach others about the way we're going to move forward, in cancer care. So you are all pioneers, and I'm talking both doctors as well as patients, and I think we're really very lucky to have one another, and only things I see, straight ahead is I see a cure, and we're going to get to it, and we're going to get to it while we're still all here, okay? So keep up the good work, and thank you so much for being here.
He said it all. He said everything I had to say. I want to say thank you very much for coming over. I think it has been a great experience, and we'll see you at the next workshop. Thank you very much.